Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Longer-Term Outcomes of Letrozole versus Placebo After 5 Years of Tamoxifen in the NCIC CTG MA.17 Trial, Analysis Adjusting for Treatment Crossover by Han Jing et al. My name is Stephen Kum, and I am Director of the Breast Medical Oncology Program at Beth Israel Deaconess Medical Center in Boston, Massachusetts, USA. My specialty is medical oncology. Title, Adjusting for Treatment Crossover to Enable Analysis of Longer-Term Outcomes in the MA.17 Trial. The NCIC MA.17 trial is one of the most important investigations performed in the setting of early breast cancer. The study was designed to explore the value of extending adjuvant endocrine therapy beyond a 5-year standard course of tamoxifen. While tamoxifen reduces recurrence by 47% and improves overall survival by 26%, a substantial proportion of women with hormone receptor positive early breast cancer will nevertheless experience a recurrence, and more than one-half of these events are seen beyond 5 years from diagnosis. Although the overview analysis demonstrates a carryover effect from the initial 5 years of tamoxifen therapy, data available in 1998 did not support the use of tamoxifen for longer than 5 years. The MA.17 investigators therefore sought to evaluate the role of the aromatase inhibitor letrozole in women who had completed 5 years of adjuvant tamoxifen. This strategy both prolongs the duration of adjuvant endocrine therapy and introduces a second, highly active agent with a different mechanism of action and no estrogen agonist activity. Since the use of aromatase inhibitors was and is limited to postmenopausal women, this trial was performed in postmenopausal women with hormone receptor positive tumors. 5,187 women were randomized to either letrozole or placebo in this double-blinded study. All women had completed between 4.5 and 6 years of tamoxifen and were randomized within 3 months of completion of tamoxifen. While all women were postmenopausal at the time of randomization on MA.17, women who were premenopausal at the time of initial breast cancer diagnosis 5 years earlier and who became menopausal during preceding therapy were eligible for MA.17. At the time of the first protocol-specified interim analysis, the stopping boundary for disease-free survival was crossed and a trend was noted in overall survival. On the recommendation of the Independent Data and Safety Monitoring Committee, the trial was stopped, unblinded, and reported in November of 2003 with a median follow-up of only 2.4 years. Crossover to 5 years of letrozole was offered to those who had been on placebo. 61% of women receiving placebo crossed over to letrozole at a median of 2.7 years from randomization, range 1.1 to 7.0 years, while 31.1% of women did not. 7.9% of women on the placebo arm had experienced recurrence before the unblinding. In the initial report, the 4-year estimated disease-free survival for women receiving letrozole was 93% versus 87% for those receiving placebo, p less than 0.001. In this trial, DFS events included local, regional, or metastatic recurrence or contralateral new breast cancer. 42 women in the control group versus 31 receiving letrozole had died. P equals 0.25. Despite the early unblinding of the trial, many important results have been forthcoming from MA.17. In an intention to treat analysis with a median follow-up of 64 months that includes the post-unblinding data, the disease-free survival remains highly significant, but no significant benefit is observed in either distant disease-free or overall survival. This trial is the only early breast cancer aromatase inhibitor trial that compares an AI to a placebo control, albeit following 5 years of tamoxifen. Thus, it has yielded information about toxicity, tolerance, and quality of life on aromatase inhibitor therapy with more clarity than other early breast cancer trials which compare women receiving an AI to those receiving tamoxifen. Further, there have been several provocative exploratory analyses on the MA.17 population, although these findings do not have the weight of a pre-specified statistical analysis. At the time of the unblinding, a large number of women who had been assigned to the placebo arm crossed over to letrozole. Although this was a voluntary rather than a randomized assignment, the comparison of those who did versus did not cross over suggests that the initiation of letrozole even more than 3 years after completing tamoxifen might still have an important impact on disease-free survival, distant disease-free survival, overall survival, and contralateral breast cancer risk. Finally, a recent presentation by Goss reported that the subset of women who were premenopausal at diagnosis and became menopausal during the years of prior adjuvant therapy had a larger DFS benefit, more than twice the overall trial result, from extending endocrine therapy with letrozole. Early unblinding and crossover in MA.17 has also had adverse consequences. The opportunity for longer follow-up for the primary and secondary efficacy endpoints, most importantly overall survival, defined in this trial as death from any cause, as well as observation for long-term toxicity, has been lost. Further, the NSABP B33 trial was abandoned after the unblinding of MA.17. In the present manuscript, the authors have applied 2 different biostatistical models in an effort to compensate for the unblinding and selective crossover of subjects in MA.17. The goal of doing so is to achieve longer follow-up so that the effect of extended adjuvant endocrine therapy on efficacy endpoints can be further assessed. The authors employ an inverse probability of censoring weighted IPCW Cox regression model, which has been previously applied to adjust for selective crossover in the Big 198 trial. To support the findings of that model, a Cox model with latent hazard rate, as described by Xiao, Chang, and Chow, the SSC model, was also performed. After unblinding occurred, women who decided to be crossed over from placebo to letrozole versus those who did not were statistically significantly more likely to be white, younger, have an ECOG performance status of 0, have a longer interval from diagnosis to randomization, have positive axillary nodes, have positive hormone receptor status at diagnosis, have prior adjuvant chemotherapy, and have an axillary dissection. These characteristics were used as covariates in the 2 statistical models. At 64 months of follow-up, the adjusted hazard ratios in the intent to treat analysis were 0.68 for disease-free survival. Confidence intervals 0.56 to 0.83, p equals 0.0001. 0.81 for distant disease-free survival, confidence interval 0.63 to 1.04, p equals 0.09, and 0.99 for overall survival, confidence interval 0.79 to 1.24, p equals 0.83. When the models in the current manuscript are applied to adjust for treatment crossover in the trial, the benefit of letrozole statistically significantly improved in all efficacy endpoints. In the IPCW model, the hazard ratios were 0.52 for disease-free survival, 0.51 for distant disease-free survival, and 0.61 for overall survival. In the SSC model, the hazard ratios were 0.58 for disease-free survival, 0.68 for distant disease-free survival, and 0.77 for overall survival. The results presented in this manuscript provide some added confidence in the efficacy of letrozole as extended adjuvant endocrine therapy. The values with respect to disease-free survival seem secure, since even the intent to treat analysis at 64 months shows a significant benefit. However, we have learned from the other adjuvant endocrine trials that compare tamoxifen and aromatase inhibitors in the first 5 years post-diagnosis that a disease-free survival benefit may not translate into a significant improvement in overall survival, even at 10 years of follow-up. This is particularly important when considering an older patient population where there are competing mortality risks. In MA.17, median age at enrollment was 62. To date, significant improvement in overall survival with letrozole in MA.17 has only been seen in exploratory analyses and now in these models. Are models enough to bank on? No. Models are only as good as the assumptions on which they are based. The authors of this manuscript acknowledge that their assumptions cannot be verified, although there is some data to support them. The models employed are complex, and fully understanding them seems beyond the expertise of most oncologists, leaving a level of discomfort for the reader. Further, a model used to verify the result of another model may add strength in numbers, but each has the same underlying problem. Would it have been better if MA.17 was not unblinded? From the point of view of the purity of results of this important trial, surely. However, there were predefined stopping rules based on ethical considerations regarding a disease-free survival difference, and that emerged in the first interim analysis, accompanied by a trend, not a significant result in overall survival. What level of findings warrant unblinding remains a topic of controversy. This is illustrated by the conduct of NSABP P1 versus IBIS-1, and now potentially by MAP3 versus IBIS-2. The MA.17 trial is an important and pioneering study. Recurrence is delayed when endocrine therapy is extended with letrozole, and there is a strong suggestion, though short of proof, that overall survival is improved as well. We continue to address the fundamental question as to the optimal duration of endocrine therapy in early breast cancer. Does long-lasting recurrence risk necessitate long-duration treatment? Accrual for MA.17R is now complete and will address 5 versus 10 years of an aromatase inhibitor in this setting. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.